Good morning, everyone. Thank you very much indeed for being here today for this symposium on medical education, with particular focus on what would happen after 2023, as the World Federation have recommended that medical schools must fulfill certain criteria before they can continue to be accredited, at least by the ECFMG or the Commission for Foreign Medical Graduates in America. Very important to welcome Dr. Arif Al-Arabi from the University of Western in Canada, and former program director at the Department of Anesthesia, Program of Surgery at the Royal College of Physicians and Surgeons of Canada, including RCI International. Thank you very much indeed, and I hope that you'll enjoy the presentation. Is in two parts. Part one, make sure that you also listen to part two, and thank you very much indeed for joining us online.
So it's really a pleasure to be here with you. So I'd like to thank Dr. Rida and the teaching staff for the Libyan International Medical University to giving me this chance to speak about one of the what's described now as the revolutionary changes in the medical education. And it's also, as I will show in one of the slides, it's described as the biggest change in 100 years in medical education. I tried to combine 3 lectures I usually give, so we can cover some of the important topics and challenges that we face either locally or internationally. One is the competency-based medical education. The second is the university and medical school accreditations as required by the WFME. And then we can highlight some of the international accreditation standards. At the end, I would like to hear some of your notes and discussions, so feel free to write down your questions as we go. So I divided my talk into 3 main subjects. Number one is I tried to convince you about the reasons why the world and the main medical schools or colleges, they look for the change. The second is we try to explain some of the facts and background of the competency-based medical education. And then we'll talk about the new accreditation standards. I'd like to mention the conflict of interest as any other speaker. So do I have a conflict of interest? The answer is yes. And this is mainly because, as Dr. Rida presented before my talk, I did my training in Canada. I was heavily involved in the medical education in Canada, and I was part of the CBD, which is the equivalent to the CBME, Competency-based Medical Education. So my understanding to the Canadian system is better than the other systems, and doesn't mean that the British or the American, Europeans or other systems are of any inferiority. As I said, competency-based medical education is described now as the biggest change in medical education in 100 years. The 100 years date is based on the work that was done by Abraham Flexner in the United States and Canada in 1910. And I will highlight some of those changes later on. But this is a good article to describe the historical background of the change. So why do we need to change? I mean, if you look carefully to the Canadian, the American, the British, the Australian, some of the Europeans, they do graduate good specialists and educators. So why they needed this change? The process of change is very complex and very long. So I try to describe 10 reasons for the change. Number one, it's an older system. And again, older system doesn't make it a bad system. But there are a lot of changes in 100 years in the landscape of all specialties, the public needs, the advancement in technology, the emergence of the subspecializations in medical fields. So people always look at their needs and then make changes accordingly. And this is the picture of William Osler. I think he's known to most of the medical educators. He's the one who brought the bedside teaching to the medical education. In the past, it used to be behind closed doors. So and then there was a lot of changes, or there were a lot of changes during the 100 years, but none of those was described as a major change. The second reason is those countries and programs and departments, they aim high. So they have very robust governance structures and quality improvement programs. And they do evaluate, they stop after certain years or maybe decades, and then they evaluate their training systems and their healthcare system, and then they make changes accordingly. This is what's described as the Romano report. Romano is the person who led the team in Canada to study the healthcare system and medical education in Canada. And as you see, he's describing, or this is copy and paste from his document. Education program should be changed. So he's really, there's some anxiety and worrisome that there's something wrong or the program is lacking some of the needed items. So, and that's what made the Royal College of Physicians and Surgeons of Canada or the universities to think about the competency-based medical education. The CBD is the Canadian brand of CBME. So you'll hear me saying CBD, which is the competence by design. It's the Canadian brand of competency-based medical education. The second one is it's a British example, and this is a very interesting report, and I advise all of you to look at it and make some reflections on it. So it's by David Greenaway. It's known by Greenaway report. He and his group in 2013 published this document, and he also came up with very warning sentence and requests that if you look carefully, there should be an immediate discussion about setting up a UK-wide delivery group to take forward the recommendations. Postgraduate training should be changed. We're talking about one of the best postgraduate training programs. And all of it, you will see immediately and should in all the documents. And this is a group of professionals who wrote this. So they discovered something very alarming, and that's why they wanted to make changes. Now, there are some alarms that were known, even this one is 9 years ago, based on one of the surveys that they sent to the postgrad graduate, and 10% they were not confident to take up a new role as a consultant. It's 1 in 10. You may say it's a small number, but it's actually, it makes a huge difference when you look at the requirements of a consultant and the impact of one consultant in the society. The second alarm, this is relatively new in 2013, and you can find this in the PMJ 2016 publication. The third most common cause of death in the United States was medical error. Again, we're talking about one of the best systems, training systems in the world. It's the American system, and they're leaders. However, we're not even counting the medical errors that are not recorded. This is based on what's in the documents. So this number could be even higher. There's almost half of the deaths because of cancer, but I think we do think that this number can be close to the second cause of death. Again, we're still in alarms. This is, I think, in the United States. 90% of the medical, legal, and disciplinary claims against physicians, they weren't against skills or knowledge, or they were against professionalism, which include attitude and behavior. So that makes them think that we should focus on those skills, and I will show you how they did that. Another one, this is I think they used the chance, they combined all the factors and concerns that I talked about to also include, to include the failure to fail concept, which has been there in medical education for decades. It's a problem in the medical education that we can't really objectively see the bad apple. When I say objectively, that you can, with documentation, with a very clear picture, you can identify the bad apple, and then you can take actions, and you will be very supported. So most of the solutions they created for competency-based medical education, they do target also failure to fail concept. And now this is a relatively new concept of the T-steeping model of medical education. And interestingly, we only saw this after we created the competency-based medical education. Now, because we can compare, because there wasn't another system in the past to compare with the T-steeping, which basically, it's a time-based and not outcome-based. You put the tea in the hot water and then wait. And then at some point you say it's ready. Very subjective. Some people may start drinking the tea after 5 minutes, some they may after 10 minutes. It's very subjective. Each one of us would like the tea in a different way. It shouldn't be like this. Additionally, we don't know during those 5-10 minutes what's happening there. We don't know. And that's exactly what's going on now with the training systems that for 5 years we train people to be consultants. We do have robust assessments and evaluations in training exams and so, but we don't see the true picture. And also this can be related to the previous slide. So that's why there's the issue of failure to fail. And we focus on finishing rotations and passing exams. And I always reflect on some of the countries, and including our home country here, is for postgraduate medical education, we do focus on the exams. The Libyan board, Arab board, masters, diploma, so on. But we don't focus on the training. And as I said, the need for more focus on the non-technical skills. Again, I use the Canadian example just because I'm very familiar with the Canadian example, but there are other examples in the British system and the American system and how you use the non-technical skills. Although I use the non-Canadian term, so what we call in the Canada called non-medical expert rules, we call them. The reason is the medical expert includes knowledge and skill and technical skills. When you say non-technical skills in most of the systems in the world, they don't include the knowledge as non-technical skills. So there's some confusion around it. So that's why we do use the medical expert in the center of the flower, and that includes knowledge and technical skills. And then around them are the 6 CanMEDS, or Canadian Medical Education Directives Specialists. This is the 2015. This is the most up-to-date one, but we changed manager to leader. And it did take years for the Royal College to change this, based on many facts. So, and it also gives you an idea how careful people about medical education, and they don't just make subjective changes. Basically, leaders can be managers, managers cannot be leaders. That's just a simple definition, but there are other differences between the two. Scholar, which means the skill of conducting research, teaching, having the academic framework of the trainee, how to also include how to critically appraise articles, evidence-based medicine, and so on. Professionalism, as I mentioned, mainly for the attitude and behavior. Communication, this is mainly how to communicate with families and patients. Collaboration with peers and other team members. And then we talked about the manager or leader. And then the health advocate, which is like the trainee will be a representative of the specialty and is an ambassador for the for the specialty. So they advocate for their own specialty and also healthcare in general. So they did change the leader. But in 2015, the biggest two changes that they made is adding quality improvement. So each of those contains now a quality improvement. So even the medical expert. So the knowledge, we teach people about quality improvement. We assist them also about quality improvement. Research, the same thing. So there are requirements in all the 7 CanMEDS or rules. We do call the non-medical expert, we call them intrinsic CanMEDS, because if you look carefully, they come from within the trainee or the physician or the person. Whereas the medical skills, the knowledge and skills, they come from outside. So the communication from inside, collaboration, leadership, scholarly, they do come from within. So we call them intrinsic. So if you come across the word intrinsic CanMEDS, it means the non-medical expert, the other 6. And then patient safety. So they included these 2 in all of the CanMEDS. And this was the first step toward the competency-based medical education in Canada before designing the CBD, is that they worked on the CanMEDS. If you look carefully, we're talking about the human physician here. How to create not just a surgeon or a physician who's very technically very good, very knowledgeable, but we talk about the human side of the physician, and that's what's needed. And as I said, 90% of the medical legal issues in the United States against physicians, they were because of the professionalism, because they, I wouldn't say lack, but at least deficient of the human side of them. Number 7, remember, we're talking about the reasons why they needed the change, why they needed the competency-based medical education. Who should drive the training in an adult learner? I mean, all of these people, they finished medical schools, and in Canada and United States, they do undergrad studies, and then they go to medical schools. So they're adult learners. They can have an active and interactive role in the training, and they also can lead within the training environment. So the focus in CBME is to give the trainees more active role in the training environment. And this indirectly will make them gain more respect when they interactively communicate with teachers and leaders in the medical education. Indirectly, they will gain the confidence and the role, and also will enable them to learn skills early on, especially in medical education. And then number 8, I put this as a lack of practicality in current systems that use competencies. And I give 2 examples here. One is from the British system. When you say clinical parts of the curriculum, there are hundreds of competencies listed. In the basic, there are 828 competencies. If you look carefully, if you want to target each one of them and teach it, include non-technical skills, assess the one competency, this will take forever to finish 828. We're only talking about the basic ones, okay? And the intermediate, there are 521. So they're okay, the intention is good, but it's not practical in terms of when you see how the teachers target those competencies, either teaching or assessments. The second is, this is from the Canadian National Curriculum for Anesthesia in Canada, which is my specialty. We have almost 100 pages, and it's like an index. So each page have, I don't know, 20, 30 lines of requirements. That's what we thought the anesthesiologist should have at the end of their training. And again, it's not very practical. We worked for 6 months, I remember, in our university to extract the curriculum or the schedule for the academic lectures, and it was very hard to cover everything. So they need more what I called as functional training units. Something very functional, can avoid all of those issues, can be targeted easily, can be understandable, and more practical. Number 9, I think I did highlight some of the issue of differences between objectivity and subjectivity in medical education. But currently we have a lot of subjectivity, either in teaching or in assessment. So with CBME, we target to change this scale to have more weight on objectivity. Number 10, I do present this slide everywhere and ask the audiences, what do you see here? So can you tell me what do you see? Mona Lisa. And my next question, how did you know that it's a Mona Lisa? So based on previous experience. If you see it the first time, it's not a beautiful picture. What made people love the Mona Lisa picture? Because if it's a very fascinating piece of art. This is not a very fascinating piece of art, but you recognize it. Based on previous experience, everybody say this. But this is the Mona Lisa, okay? So this is what we graduate actually now. We see people go over 4 or 5 years of training, they graduate as physicians, they wear the white coat, they have a stethoscope, they're physicians. Do we really, can we differentiate clearly between the different Mona Lisas or different graduates? I don't think so with the current system. So the CBME, they're focusing in adding more pixels to this picture so we can see it. And this is why the assessment is the main backbone of competency-based medical education. We create tons of assessments. The jump in number of assessments is unbelievable. And I'll show you one of the slides, how many assessments we do now compared in the past. So we do need a clearer picture for our graduate. This means we will have a better product. Now, there's now a lot of people now working on this concept is to connect all circles, all medical education circles. So, when people come from medical school, go to residency, to fellowship, to independent practice, they may go back to teach again or go to retirement. So this all should be a monitored process. You can't, that's why, especially in the United States and Canada, people do not work independent here. And this is something probably we should think about and discuss and explore. Do we need medical school students to practice on their own after graduation with the bad picture of Mona Lisa? So can we? Is it fair for our patients and families to do this? So there's something that needs to be explored. I don't know the answer, but it's something that needs to be explored. And so on. Again, same thing. When people graduate from training and they become specialists, they shouldn't feel that they're done, totally done, 100%. But there should be what we call the CPD, continuous professional development, with a very close and robust monitoring process. So those are the 10 reasons. What I gathered them. There could be more, but this is just to feed your thoughts and try to convince you why those programs are trying to make the changes. Now, why should we focus on the training structure? To make all of these changes, you can target the learning process at different stages. But most of the programs now in departments, they think that we should target the factory, the main structure, because good factories produce good products. So if you focus on the structure, then theoretically you may end up by having good product. Now, CBME, which is competency-based medical education, I'll give you just brief definitions, but I will go in more details in explaining those terms. So as we say, this is, now we know, competency-based medical education. CBD, as I said, is the Canadian brand, competence by design. And then this is the biggest, probably new addition in medical education. It's the EPA. It's called Entrustable Professional Activity. It's developed by this person in 2005, okay? And since 2005, he's tried to explain, because it's not a usual term, a term used by the medical field, and people found it very hard to understand the concept. And to be honest, we had the full understanding when we started practicing with EPAs. But one of his talks in 2014, he said the work that must be done. Basically, if you expect a surgeon to be competent at the end of their training, you divide their competencies and skills and required skills into EPAs. So one EPA could be, and I'll give you more examples. So it could be manage, let's say, laparoscopic cholecystectomy, for example. Okay, that could be an EPA. Within that EPA, you will include the technical skills, you include the non-medical expert, non-technical skills, and so on. And it will be progressive, which means, you know, what do you require from them at level of year 1? What do you require of them at level of year 5? So, and I'll explain that in more details. I think as soon as I give you examples, you'll understand the concept. Each EPA will have milestones. So as I give you the example of the lab Coley, it does have milestones. And this is the picture from the Royal College website. So milestones at the final, and they give you the EPA. So if you have questions about it, let's wait and see the examples. If you still have questions, we can discuss it later on. There's a lot of definitions about competency-based medical education, but I found this very simple. I think doing the right thing at the right time, in the right way, in complex situations. I think it gives me the sense that this person is competent if they do the right thing in the right time, in the right way, in complex scenarios. If you take this to the educational piece, I add it in front of the right teacher. Because if there is no right teacher, you cannot see that. And that comes the importance of updating the teachers and consider them as one of the main stakeholders when it comes to CBME. Interestingly, it's not a new concept, but we didn't pay a lot of attention to it. This is from the WHO, and it's 1978. They talk about competency-based curriculum development in medical education. Huh? 78. Yeah. Okay. So they talk about, but the EPA, to my knowledge, came out in 2005 by the Ten Kate. He's a Dutch educator, and he's well known about the competency-based medical education. Now, another example, I'm trying to explain to you EPAs in different ways. I did steal this from one of my colleagues at the Royal College, so I like the concept. So this lady, we think now we can trust her to drive a car. So the moment of giving the key, which means this person here was convinced that she met all the criteria. She passed her written exam. She was observed during the drive and convinced the trainers. And she passed the final test, and now that's an EPA. Driving a car is an EPA, okay? It did replace what we know, goals, objectives, or ILOs. So whatever you use, in Canada we use goals and objectives. Here mainly intended learner outcomes, okay? You can think of them as ILOs, but don't use them as ILOs, okay? So you can think of them. And I call this as the functional unit. Without it, nothing, you can't do anything within CBME. If we think the human cell is the functional unit of the human body, think of the EPA as the functional unit of CBME. Now, we started with the postgraduate medical education first, and we made changes. And in Canada, July 2017, we started with 2 specialties. One is my specialty, anesthesia. The other one is otolaryngology, which is the ENT specialty. So 2017, we did start. But at the same time, the undergrad group, they were working on having EPAs for medical schools. So I think this is more relevant to your university, just to give you an update on the work that has been done in both Canada and United States. Why they needed to work at the level of medical school? Because of what we said, connecting all the dots, and you should have continuity in medical education and continuous monitoring. So you can see the novice here to the expert, competent. I'll show you another slide to explain this more, but this medical student, year 3, their medical school is 4 years after undergrad, and then PGY1, which is postgraduate year 1, postgraduate year 3, and then they continue after they graduate to the expert level. So you need it, if you start EPAs here or competency-based medical education, it makes more sense to also have it here and make it as a continuous, so you don't have to repeat things, as you go.